Hello everybody, my name is Lynne Maher and I'm the Director of Innovation at Awatea, which is part of the county's Whaanau health system in Auckland, New Zealand. And now that Renee, who is my partner in crime, has introduced herself, I am going to introduce myself as well. I've already told you my name, but I have a passion about imagining this future where staff and consumers consistently, and that's an important word, comment on how wonderful their experience of health and care are. You know, we've been trying hard to achieve that, not only in Counties Whaanau Health in Auckland, but in many countries. But we're not there yet. And actually, I think, you know, we've had a bit of a wake-up call that we need to work in a new way. We need new leadership and we need new partnership, because thinking we can stay as we are is the height of systemic delusion. And, you know, it's this wake-up call that we're looking for. Now, what's different? You'll see in this picture of me when I was in my nursing career. You weren't allowed to smile at that time. This was a ward charge nurse's uniform and we had to be really stern. But the important thing about my training as a nurse was that I was very specifically trained to do things to and for patients. So I was the only expert and the patient had to listen to what I said. And actually, I think we're moving a little bit from that, aren't we? We are definitely moving to a place where we want to work with patients in partnerships and actually share that leadership. But it's slow moving and we can do something about that. Now, Renee and I, even though we're in different countries at the moment, we desperately wanted to show that we do work together and that we do share this leadership and this new way of working. So she's there with you, but she's also here with me and is going to come and co-present with me now.
So it wouldn't be Australia versus New Zealand without a bit of competition. So we're just going to give you a bit of the lay of the land as we see it and understand it. So in New Zealand at the moment, we've just launched our new New Zealand health strategy. And through part of that, they had overwhelming feedback about the need to focus on people, how to engage better with them, and how to design services together and get a better understanding of people's needs. So in New Zealand, we have a Health Quality and Safety Commission. Now, with the Health Quality and Safety Commission, one of their portfolios is consumer engagement, but we don't have any organisations that consumer engagement is their entire portfolio in terms of supporting consumer engagement, supporting the district health wards as to how to go about it. That's something we don't have at the government level. So what we're looking to do is integrate that through our district health boards and provide support networks across the country so that those of us that are working in patient experience and co-design can actually support, coach and mentor each other. So that's how we see it here in New Zealand, and obviously we'd like to progress and change that so it becomes a lot more visible. But the new health strategy is definitely a step in the right direction. In terms of Australia, we see that you've got a lot of consumer professional bodies to help support and give a visible voice to consumers that might not always have that visibility, and give them a place to go and to start to know where to help and how to help. So that's something that we see as a really positive thing that you have, and that we'd like to aspire to something of that sort of nature in New Zealand. Now, more locally, our team here at Counties Whaanau Health is obviously Lynne and myself, but we work in a much wider team. So we link to our Patient and Whānau Centred Care Board, or Patient Family Centred Care Board, as you would know in Australia. This basically looks after the portfolio of consumer engagement, patient experience, patient and family centred care. All of those components sit under the Patient and Whānau Centred Care Board. We link directly with our executive leadership team, hospital management teams, our volunteer services, consumer council, and also our quality improvement team being a huge driver to help us create a sustainable way of getting consumer engagement and co-design across a whole organisation, in terms of building that people power that we have and spreading that out, so we can have more visibility, more support and more coaching. So Lynne's now going to talk about the true partnership of co-design and how we create that as an organisation here at Counties.
Thank you, Renee. I'm going to really go from where Renee's taken us from the sort of high-level strategic context into, so what do we do on the ground? And what we're trying to do is have a true partnership between anybody and everybody who's involved in that care journey, whether it be through the hospital, whether it be out in the community or in any other place. And we want a true partnership. What we do not want is what this cartoon slide is showing, you know, will this lollipop suffice for engagement? The answer is no. This is not about tokenism. It is not about something very simple that we do and to tick the box. What we try to do here is work within a systematic process that takes us right through to co-design. Co-design is part of an improvement process. Lots of people come up to me and say, oh, I'm co-designing. And Renee will be laughing now because I always wait and then say, really? What are you doing? And what we find is people are typically just capturing experience, and then they, as experts from the staff perspective, are going away and then, you know, taking that knowledge and designing. That is not co-design. We use this process that's on the slide now, and I'm going to take you through some of those components. First of all, of course, we identify a challenge or need, and we can do that in many ways. It might be a strategic need. It might be a need that's been identified through complaints. It might be a need that's been identified through mounting safety challenges. Whatever it is, it doesn't matter, but that's the first thing. What are we going to work on together? Once we've identified a challenge or need, we need to then move on to the next step, which is thinking very seriously about how we engage with our consumers, families and staff. Now I'm going to focus more on the consumers here. Engaging with staff is important, but you know, this is all about consumers and families. And you know, we have to think about the context that those consumers and families are in. So in our county's Whaanau health area, we are so lucky. We've got rich and diverse communities. We've got communities who are from the Maori culture. We've got communities from the Pacific Islands cultures. We've got communities from Chinese culture, we've got communities from the Indian culture, and also the white European cultures. All are really important, and there's synergies between them, but actually they all have subtle differences. So this is about context. One size does not fit all. We have to think about how we're going to engage and use methods that are really comfortable for those people. Now, we often use clinical staff to identify consumers for us to work with, and there's often a little bit of reticence about that because people say, well, clinical staff will only identify those people who they know are happy and like them. What's really important to remember is we want that. We want to know what's going really well so that we can preserve and build on that. So, you know, never shy away from that. Equally, we can identify people who may have complained, people who are not happy, and we can identify people just in the wards, in our departments, as they're going through care. The important thing is to frame things well so that they feel safe when they're talking to us. What we've learned is actually we don't need high numbers of people to engage with. We can do that, but equally we often get data saturation from just a few narratives, a few stories about what it's like to receive care. So we also use a downloadable leaflet from the Health Quality Safety Commission here in New Zealand, and that was co-designed with staff and consumers, and in fact Renee is featured in that guide, so please do have a look at that. It's free to download. When we've engaged people, then we move on to the capture stage. And as we're capturing experience in different ways, we can also ask consumers and families and staff for their ideas of how we can make things better. Now, once again, the way we capture can be very particular to the culture, but we absolutely use surveys, but never alone. We always want a method that brings us more depth, more richness. So we often use shadowing or observation or stories, diaries, focus groups and panels, a whole range, but it depends on the consumers that we're working with and how comfortable they feel. Once we've captured that data, we've got a real richness, and what we do is map that richness. So we're looking at those emotion words. As we capture, we always say to people, how does that make you feel? Because we're looking for those emotion words. And we can do a process map or a care journey map, and then add those emotion points. Where an emotion links in with a process point, the term used is touch point. And that means we can identify parts of the process that are generally going well for people or providing exceptional care, and those that aren't doing so well. And that helps us to understand how things are now, and we can use the maps again when we've improved care. These maps can be used in very, very large journeys, or they can, like this example, which is from Christchurch, and it's a journey actually through the emergency department right to being admitted to a ward. They can be much larger than that, or they can be quite small, as in the second example, which is from the Waikato region, and it's about people using and staff answering the call bell in a hospital. So we can use any portion of a care journey and really understand what's good and not so good for that. Basically, when we've captured, when we've engaged, we've captured and we've mapped that experience, this is the time when we co-design. We've been working together so far, but we continue to work together to say, what are the ideas telling us? How can we prioritize what we work on, and how can we continue to work together to improve those services? Now, all importantly, we mustn't forget that we need to measure. And, you know, depending on the kind of work, we will use measures that are relevant to those pieces of work. But what I would say is never forget what matters more than that raw data or data alone is trying to place those facts in context and deliver them with emotional impact. Data that has, you know, graphs and things like that, and stories or some emotional impact will have more impact on the people that you're working with. And basically, that is where we have finished our process, because we can measure the improvement as we go along and at the end demonstrate that impact. And that's what we do day in, day out as we're working to co-design with patients. Now, some of the ways we're working and how we support and influence others is coming up next, and I'm going to hand back over to Renee to talk to a couple of the bullet points in this list. Renee.
So one of the ways that we look to support our staff and patients and families that we work with is one-on-one coaching and mentoring. Now, I want to emphasise that we provide that both to staff and to patients and families. So this is where we also start to use the skill set of our team in terms of who supports the different groups that we work with, depending on what stages of their projects that they're at, in terms of using our skill sets to the best of our ability and our resources, but also who's the best fit and relationship that's been built with those staff or patients and families out in the community, because a lot of the culture here at counties and in the communities that we work with is about relationship building, and without that relationship being built, we don't get very far. So it's something that we work on really, really strongly. And another thing that we do quite prominently now is also a lot more networking and engaging with social media in terms of influencing other organisations, but also being influenced by other organisations too. What are they doing? What can we learn from? How are they doing something differently? What cultures and demographics are they working with that we could try and apply here at Counties Manukau Health? How are they supporting and coaching and mentoring their consumers? And again, how can we bring that back to help our teams and then share with the likes of you so that you can share with your teams? And it's one big growing network of skills that we're building globally.
Another couple of areas are around how we continue to build capability, perhaps a bit more formally. So for example, masterclasses and presentations. And when we run masterclasses, we always like to, especially if project teams are there, we always like to have not only staff but patients and family members as well, so we can learn together. This is not about staff having special learning and then consumers, patients, family members just being bolted on. No, we start by learning together, and so we run those here and around the country. Also, what Renee and I have been trying to do is link with our local universities to embed some early training, for example, into nurse training, so that when the nurses come out into the ward areas and department areas, they know what's expected and they have an idea of what we mean when we're talking about co-design. They see the active partnership going together. As Renee said, actually we're always keen to learn from others, and we're fortunate that we get invited to help train others, and every time we go into a different organisation in Australia, in New Zealand, elsewhere in the world, we learn a little bit more about what they're doing, their context, and what tools and techniques they're using, and we use that learning to continue to build our learning. So that's kind of how we use our process, and generally how we then help capability building. An important thing is this quote that you'll see now from Charles Darwin. In the long history of humankind, those who learn to collaborate and improve most effectively have really prevailed. And I think the whole thing about co-design is a different way of working between staff, patients, consumers and family members to benefit everybody's health and care. And in the true spirit of partnership, Renee and I wanted to be together on this film, but now I'm going to hand you back to Renee, who's going to carry on telling you a little bit more about the way we work. And I wish you have a wonderful forum, and thank you very much for involving us. Bye everybody.